Welcome to Mastering and Guideline in Ultrasound and Echo.
Hi everyone. Cardiac cycles or the all events that happen during one heartbeat is the most important and fundamental concepts of the physiology of the heart that first time by Dr. Carl Wiggers over 100 years ago explained and detailed very well that since that time they put it his name as a Wiggers diagram, and it show all those event changes during cardiac cycle. Around 2007, Dr. Bruce Wright add to this diagram some more information about especially those hemodynamic and pressure change in those chambers of the heart and even venous, IVC, and pulmonary vein. And it take his name after him. We called it a Wright table that later we talk about that. Before we start the Wiggers diagram or cardiac cycle events, I would like to explain some terms that we use for cardiac cycle. First of all, when we say cardiac cycle, our reference is mechanical cycles, not the electrical cycle. As we know, electrical cycle start with the depolarization of the SA node and create P wave, and then finally to the ventricles that create a QRS and depolarization of the ventricle T wave, and this cycle repeat. That is electrical cycle of the heart. But when we talk about cardiac cycle, means mechanical cycle that start with contraction of the ventricles and relaxation of the ventricles. That is the definition of cardiac cycle that we called it systolic and diastolic. But we have to remember that when we say systolic, both atrium and ventricle, they have both systolic phase and diastolic phase, but at the same time, completely opposite each other. When the ventricles are in the systole, atria are in the diastole and vice versa. So just keep in your mind. Now let's go start with our cardiac cycle diagram. We started with the systolic phase or contraction of the ventricles. The events on the both side, left side and right side, is the same. Only the pressure compared to each other a little different. But the all details are the same for left side and right side. Here, I am focusing and bringing an example on the left side, but it goes the same changes and timing to the right side too. Here we have, all those events correspond with EKG or ECG. And always we have to remember those changes and corresponding with the EKG. We have many parameters and component in diagram. One of them is pressure on inside of the ventricles, atrium, and aorta, and that we have a unit for the y-axis or vertical is pressure gradient or pressure, and unit is millimercury, and the horizontal or x-axis is timing. For the other parameter, including EKG, we use different unit on the vertical or y-axis. Later on, I am going to add on the volume of the both chambers during cardiac cycle and add that chart later that bring everything together. Now let's start with the systolic phase. Before we go systolic, as we know, systolic phase start with QRS complex. That is our systolic phase. But before we go start systolic, let's have a look at the end of the diastole. What happened at the end of the diastole and then start a systolic phase. Here we have a heart, 5-chamber, 4-chamber of the heart, as you can see. In this three of them, you will see the heart at different timing of the EKG. Here at the end of the P, here is the red spot. You can see red spot at the Q, here at the S, and here is the live and moving the cardiac activity. Here is 5-chamber, here is blood flow. For those that they are students still, they don't know the echo and Doppler. Here we have color box as references. If the blood goes toward the probe, our probe is at here, at the top of this sector. If blood goes toward based on this landmark, it show red. If it go away from transducer, it show blue. So we called it, if it go toward the probe positive shift, color is red, and it goes away from transducer, negative shift is blue. Now let's go and see what happened during the cardiac cycle. During diastole, at the end of diastole, that is correspond with the P wave. P wave depolarize the atria, both atria, left and right. Here we focus on the left atrium. At the end of the P, the contractility of the left atrium means start contraction. There is a delay in all electrical and mechanical activity. We have a little delay, about a 10 to 20 millisecond delay. That is makes sense because starting to get the depolarized all that chamber, it take time. So we have a gap between electrical activity and physical contractility of that chamber. At the end of the P, as you can see, mitral valve partially open at the P when the left atrium start contracting. Here you can see correspond with the end of the PR segment. It's contraction of the left atrium push the blood toward the left ventricle and mitral valve open. As you can see, exactly that dot, red dot, correspond the timing of the EKG. And when the action potential or electrical depolarization of the ventricle start Q and go to the all ventricle, or the left ventricle start contraction. With increasing contraction of the left ventricle, pressure inside of the left ventricle increased. Imagine at the end of the diastole, left atrial pressure that push the blood to the left ventricle is almost around 5 to 8 millimercury. So in that case, the pressure of left atrium at the end of the P wave or end of the diastole, pressure between the left atrium and left ventricle become equal. With the starting contraction of the left ventricle, the left atrium start relaxation or diastolic phase of the atrium start. Left atrium relax and left ventricle start contraction. With contraction, pressure inside of the left ventricle increased. At that moment, right away, when it increased, the mitral valve suddenly closed and it create S1 on the heart sound. This pressure when increased, for example, 6, the blood doesn't go to the left atrium if we don't have mitral regurgitation. So for the aorta, it has two ways, go to this side and another to the aorta. But as we know, the pressure inside of the aorta is equal to the diastolic blood pressure. And as average, we get it around 80 millimercury. So during this time that the mitral valve closed and pressure on the left ventricle still is not over 80, aortic valve is closed too. So in this phase, still not any blood goes outside. Just the shape of the heart changed because contraction happened. So the shape of the heart changed, but the volume doesn't change because the pressure still is below 80. Only blood start going out when pressure inside of the left ventricle go over 80 or over the diastolic pressure of the aorta. It looks like you have a closed balloon and you push it and squeeze it. The shape of the balloon changed, but the volume doesn't change. That is exactly this concept. This contraction increased and until the pressure goes over 80, and that moment aorta open. As you can see here, from the closing mitral valve to pressure goes over 80, we have a timing here. This time aortic valve closed, mitral valve closed, blood doesn't go anyway. We called it this gap or this time, we called it isovolumetric contraction. Iso means equal, even, the same. So during this period of the time that we called it isovolumetric contraction, the volume of the heart left ventricle doesn't change. There is not any blood goes outside of the left ventricle. Just pressure increased little by little until it goes over 80. In that case, aortic valve start opening. Opening of the aortic valve doesn't have too much strong sound, but it still is recognizable. But since this time between the closing mitral valve and opening aortic valve here, this time, that is very short, is about 30 to 50 milliseconds. We cannot differentiate those two components of the heart sound, first heart sound. And the opening usually doesn't have very strong sound. But in some situation that this gap increased, we can detect those two components of the sound. To this time of the closing mitral valve and opening at this level aortic valve, we called it isovolumetric contraction time or IVCT. And it is on the echo we can detect it by Doppler, that shortly I am going to explain about that. With opening aortic valve, blood start goes to the aorta and pressure increase to the maximum contractility of the left ventricle, that in normal person it goes about 120 millimercury, that is systolic blood pressure. So end systolic pressure in left ventricle is the same as the systolic blood pressure on the arterial arm, except in other situation those can be a little different, like the HOCM or other situation obstruction on the LVOT. Those two pressure can be not the same. That I am not going to talk about that in this presentation. I talk in another lecture. When the contractility goes to the maximum spot and the polarization finished, the heart start relaxing and depolarization start, that correspond with T wave. In that specific moment, that is around 100 millimercury pressure from the 120 start dropping because relaxation start. When it goes around 100, the recoiling property of the arterial wall aorta and it's start pushing blood, all goes back this way and forward. When it goes around 100, this aortic valve start closing, that it create a second sound of the heart that is correspond exactly with closing aortic valve. Now Here, when we have, imagine, for example, here is 100, the pressure in left atrium is almost still the same, 3 to 5, because it is on the still not contracting, and blood come back from the pulmonary vein to the left atrium, but pressure it is around below 5 millimercury. So as long as this pressure is above the left atrium, mitral valve closed. So during diastole, aortic valve, that during this moment of the cardiac cycle, that relaxation, or that correspond with the repolarization of the T wave, relaxation, pressure little by little decreased. This decrease doesn't change anything on the mitral valve until the pressure in the left ventricle goes below the left atrial pressure. So we have aortic valve closed, and pressure in left ventricle start dropping until the pressure on the left ventricle goes below the left atrium. In that moment, when the left ventricular pressure goes below the 5 millimercury, the mitral valve will open, and that give us this two component. First component is aortic valve closing, and second component is mitral valve opening. As you can see, during this time, from closing aortic valve and here until mitral valve open, there is not any blood goes in or out of the heart or left atrium or left ventricle. To this period of the time, or this phase of the cardiac cycle, we called it isovolumetric relaxation time. That corresponds exactly around end of the T wave. Isovolumetric contraction correspond between R and G point of the EKG. For the isovolumetric relaxation time, or IVRT, is correspond almost end of the T and beginning of the completely flattening isoelectric line. To this one is almost the same time, a little more than isovolumetric contraction time, is something around 40 to 60 milliseconds. But in any different cardiac situation, these two times can change. That is one of the parameters we use, especially in diastolic dysfunction, that I talk about that in other lecture, and not here. I am not going to talk about in that lecture. You can Here you can see at the uh, S wave, mitral valve closed, and left ventricle shape a little change. If you look at the septum here, here, and here, a little shape change, but the volume doesn't change. When the pressure goes high, aortic valve open and blood goes toward the aorta. From the timing that aortic valve start open, means blood goes out, up to the timing that the aortic valve closed again during relaxation. From here to here, in other words, from here to here, second line to the third line, here to here, we called it ejection time, means blood goes outside. But the systolic times is from the R to the closing, closing mitral valve and closing aortic valve. This is, we called it systolic times. From the aortic mitral valve, again, I made mistake. From the mitral valve closing to the mitral valve opening. This is, we called it systolic time. From those time that all valve, aortic valve open and then close, we call ejection time, or the time that blood goes toward the aorta. Here we can see those changes in the blood flow inside of the heart. As you can see here, during diastole, blood goes to the left ventricle, and during systole, blood goes to the aorta valve open and blood goes, and this cycle repeat again and again every beats of the cardiac cycle. Now let's see what happened during diastole. During systole, mitral valve closed, but still blood continuously come from the pulmonary vein to the left atrium, and during systolic phase of the left ventricle, left atrium filled up with the blood, and little by little pressure increase in the left atrium. When in the end of the systole, left ventricle relax and pressure completely dropped. At that level, left ventricle at the when the pressure come completely down around below the left atrium pressure, suddenly recoiling and springing property of the left ventricle, it's open up, and like the sucking, and the pressure become here in left ventricle in the diastole less than left atrium. So at the beginning of the diastole, mitral valve open and blood rush toward the left ventricle. And after it go continue, because it feeling it continue during diastole, but since this part of the cardiac feeling happened inactive, we called it early diastolic feeling, or uh, we called it passive feeling or rapid feeling of the left ventricle, because there is not any pressure, left atrium is not contraction, is at the isoelectric level, at this level, so there is not any contractility on the left atrium. Just based on the recoiling feature of the left ventricle and feeling the left atrium increasing pressure, when the pressure in the left ventricle diastole drop, suddenly the left ventricle open and blood rush without any external force goes toward the left ventricle. That we called it early feeling or rapid feeling, that correspond after T at this level, after T. And majority in normal situation, majority over 80% of the feeling left ventricle happen at this level, early or rapid feeling, that there is not any active process in that event. When the left ventricle start feeling, the pressure little by little become even. As you can see here, this pink or violet, purple curve belong to the atrium pressure here. At the diastole, little by little pressure goes increased, because the here blood goes continue drained from the pulmonary vein to the left atrium, and pressure here increased. As long as this pressure on the left atrium is more than left ventricle, blood goes to the left ventricle. But at the mid of the diastole, because left ventricle become filled, pressure almost become equal. There will not be too much blood at the mid of the diastole goes toward the left ventricle. This phase we called it diastasis. It means is the balance between the pressure in the left ventricle and left atrium. There is not too much blood goes inside of the left ventricle. But after P wave, that is systolic for the atrium, left atrium contract, and in that time blood again go more toward the left ventricle, because contractility increase pressure more, and so this phase of the cardiac cycle of diastole, we called it active feeling or atrial contraction that correspond with the after P wave that we can see on Doppler. I will show you shortly. When it goes finish pressure finishing contractility of the left atrium, the pressure become at end of the P wave equal between those two, and the mitral valve start going close to each other. And when the electrical activity of the QRS start, the left ventricle contract and start pushing blood this way and that way, and right away with the QR wave, mitral valve closed and the cycle of the heart repeat again. Here you can see the changes of the volume in the left ventricle during cardiac cycle. In the isovelometric contraction, the volume of the left ventricle is constant and doesn't change. And in the isovelometric relaxation time is the same. With Doppler, we can detect all those events happen in cardiac cycle. For that purpose, we can use a pulse wave Doppler or continuous wave Doppler. In pulse wave Doppler, we go between 5 and 4 and put sample volume between the LVOT and mitral valve at this spot. This spot, not here, not mitral valve, between them. Or we could put continuous at this level, not mitral valve, not LVOT, between them. At this level, we can detect those cardiac events in the cardiac cycle. Here we have pulse wave. Here these two are continuous wave. Let's go detail and how detect those cardiac cycle. First of all, as you can see, we have QRS, and here we have a P wave and T wave, and repeat the cycle is the same. Here we have QRS, P wave and T wave, and so on, and here the same. During cardiac cycle, during diastole after T wave, as you can see, this strong envelope as M shape, this is belong to the mitral valve. Blood goes toward the transducer, so at early or active feeling, blood goes toward the probe or left ventricle, so it gives us a positive shift. At the after P wave, here we can see this is, we called it E wave or early feeling or rapid feeling. And A wave here after P wave give us the second positive shift. So represent contraction of the left atrium. That is the reason when we have atrial fibrillation, usually we don't have P wave, because in atrial fibrillation, the left atrium or atria doesn't contract, just shaking, not contracting, so doesn't create a wave. And here we can see there is a gap between this is belong to the aorta Doppler, because blood goes this way, negative shift. Aorta, we can see another envelope here inside that is belong to the LVOT. LVOT and aorta. Patient has aortic stenosis. Anyway, here, when you can see aorta here finishing, and here patient has AI or aortic insufficiency. Right after end of the blood goes out and finish it, regurgitation start. And you can see mitral valve blood flow goes toward the left ventricle. Here is the gap between them. The gap between them represent isovelometric contraction time or IVCT, exactly between these two. Or here the same, you can see between the ending of the blood goes toward the aorta, this is ending, and starting blood goes to the left ventricle, here E wave, there is a gap between them or distance that we can measure it isovelometric contraction time. Between the finishing and starting, here again the same. Here on the pulse Doppler, this is belong to the LVOT. LVOT, when finished, blood doesn't go. End of the systole and starting of the diastole. Here we have isovelometric relaxation time. Isovelometric relaxation time. Isovelometric contraction time is from the here to here, end of the A wave to the beginning of the LVOT. Blood flow goes outside. So when we finish it, A wave, and starting uh, LVOT, we have IVCT, or isovelometric contraction time. IVRT, isovelometric relaxation time, is the same here. Here we have isovelometric relaxation time and isovelometric contraction time here. And here we don't see, but on this one we can see ending of the uh, A wave and beginning of the aorta. There is a gap between them. That is isovelometric contraction time. The same concept happened in those the right side too, but with the different timing. The later I will a little explain. Here is the right table for the left ventricle. Those pressure changes during cardiac cycle. The first letter belong to the atrium, second belong to the ventricle, and D stand for diastole, S stand for systole. Let's go first stage in here. He mentioned it as a diastasis, or slow ventricle, that correspond between T and P wave. In that situation, pulmonary vein pressure is higher than left atrium, so blood goes, but with not too much differences, but it still goes from pulmonary veins to the left atrium. And during that time, the left atrial pressure still is higher than left ventricle, but again is not too much. That is the reason we called it slow ventricular filling, or diastasis. A little blood goes in. To the aorta, pressure is high, blood doesn't go anywhere out. During active ventricular filling, that is correspond with P wave, or atrial contraction, pressure inside of the left atrium goes high. So some blood back up to the pulmonary vein, and some of them goes to the left ventricle, but nothing goes to the aorta. This is active filling, or P wave, or atrial contraction, that correspond with atrial systolic and ventricular diastolic phase. With the systolic time, that ventricle is at the systole and atrium at diastole, or we called it systolic phase of the ventricle, pressure in the pulmonary vein increased. This pressure is higher than left atrium. So still during systolic phase of the ventricle, blood goes from the pulmonary vein to the left atrium. That is the reason the left atrium, it becomes filled up during systolic phase. But since the mitral valve closed, nothing blood goes to the left ventricle, and not only that, pressure in the left ventricle is high. This pressure during systolic go over the diastolic pressure of the aorta, so blood, aortic valve open and blood go to the aorta. During rapid filling, or at the right after T wave, both the atrium and ventricle are on diastolic phase, or relaxation. So pressure in pulmonary is a little higher than left atrium. Blood goes from pulmonary vein to the left atrium, and left atrium pressure is higher than left ventricle because it's diastolic relaxation and is almost even zero, even at the early feeling, at early few millisecond, even goes negative, and blood rush goes to the left atrium with the very high differences pressure between left atrium and left ventricle. That is the reason we called it rapid feeling. This sometimes, if it's too much differences between them, can create S3 sound. That I'm not going to talk about that. And finally, the aortic valve closed and nothing blood goes out or in through the aorta. Here are those pressure changes in the right side of the heart. As you can see, vena cava here as the pressure is higher than right atrium. So blood from the vena cava and superior vena cava, inferior vena cava goes to the right atrium. In the right atrium, pressure goes to the left ventricle during slow ventricular diastasis with the little differences between them. And pulmonary valve closed, blood not goes to the pulmonary artery. In active ventricular feeling in right side, as you can see, some in the right atrial pressure increased due to the contraction of the right atrium. Some blood back up to the IVC and SVC, and we can see those changes in the IVC and the middle hepatic vein, and some blood goes toward the right ventricle. Still pressure is higher than right ventricle, and finally the pressure is still is not higher than pulmonary artery, so blood doesn't go to the pulmonary artery. At the systolic time of the right ventricle, pressure in the right ventricle goes high. Vena cava and superior vena cava and inferior vena cava pressure is higher than right atrium. So during systolic phase of the ventricle, right ventricle, blood goes from the venous system to the right atrium, but and fill it up the right atrium. But tricuspid valve closed, blood goes, pressure in the right ventricle goes higher than pulmonary pressure, and so blood goes from the right ventricle to the pulmonary artery, and finally we have rapid filling of the right ventricle that correspond after T wave. Now let's answer to two questions about this topic. First, which of the following sequences represent the correct order of the cardiac cycle? I give a few seconds, 1 minute. So very easy. And again, remember to just take a picture with your mind and always remember this chart is very critical for everything, not only exam, for understanding the physiology of the heart. So cardiac cycle start with the systolic phase of the left ventricle or right ventricle. Start with the isovelometric contraction time. Then we have ejection time or ventricular systolic. Then we have isovelometric relaxation. Then we have rapid filling after T, blood rush to the left ventricle, filling. 80% of the left ventricle filling happen at this time from after T to halfway, and correspond with E wave on the mitral valve Doppler. Then we have slow feeling or diastasis, and finally we have active feeling during atrial contraction or squeezing or atrial systole. So based on this, isovelometric contraction time, ventricular systolic, isovelometric relaxation, rapid feeling, or atrial systole is wrong. Atrial systole is at the end. So the answer will be D. isovolumic contraction, ventricular systole, isovolumic relaxation, rapid feeling, slow feeling, and atrial systole. Second, correspond to the EKG. This is EKG or ECG. At what stage intraventricular volume doesn't change? Means it's constant. Shape change, but volume doesn't change. I know you know this. I know all of you got this one. At two stage, we have constant volume of the ventricle. One of them is IVCT, another IVRT, isovolumetric contraction time and isovolumetric relaxation time. In those two situations, all valves are closed. All heart valves are closed. So ventricle size doesn't change. Even shape of the ventricle change due to contraction, but the nothing blood goes out or in, so the volume doesn't change. And correspond to the EKG or ECG, the isovolumetric contraction start at P at 5 R wave, 5 to the S wave. So the answer is one of them is isovolumetric contraction time, another isovolumetric relaxation time. Relaxation almost end of the T wave and beginning of isoelectric line. So from here to here, as you can see on this chart, and these two. So the only answer in this question will be A. We are done. I hope it was useful, and don't forget your question. Up to the next time. Have a wonderful time.